So Dr. Kahali is here as well.
Yeah, and, Ramesh, good evening and good evening to everybody. And please accept my best regards. And we have the best of speakers. And I welcome you all as chairman. And I see, sorry, I was delayed in a case a little, left main one. So anyhow, we have the legends. Yesterday, we had a meeting with Madam Mary Claude Maurice, and we talked about the links and everything. Some problem with Dr. Meheran. Yeah, Dr. Meheran, are you okay with the links now? Yesterday there was a lot of problem. We are very sorry for it, and really it is the number one of a series of educational endeavors we are going to take from NIC CSI. That is the National Intervention Council Cardiological Society of India. And we have friends like Dr. Ramesh Dagubati in US and many others like Samin Sharma and many others over there. So with your kind, patronage, I think it will be a hugely successful one. And as you know that in India, is just in difference to the Western countries, US and Scandinavian countries, the burden of coronary artery disease is increasing, and it is going to be doubled in the next 10 to 15 years. So we need to know more and more about this technology, newer technology, and there are recent developments. So it is an educational initiative, and I think we'll learn a lot about this session. Thank you very much. Yeah, and let us start, Dr. Morris. Yeah.
Hello, should I start now?
Yeah, yeah, sure.
Okay, sorry. Thank you for inviting me. It's a real pleasure, Dr. Kahili, to be with you and all doctors around, and very happy to be with you today. So let me go to my presentation with you. Okay, and I'm not at the beginning. Okay.
Dr. Kahali, the host is ready for us, right, to start?
Yeah, yeah, sure. Yeah, they're ready for starting. Yeah.
Okay, thank you.
Okay. So the topic of today is PCI. We are around the limitation of current technologies to treat diabetic patients. This is my conflict of interest. I am a shareholder of CERC, the company with one of the company who is running the Ability DM diabetes. It's not, yes, nobody more than Indian doctors knows that diabetes is a very frequent and increasing comorbidity. This is an example of a population, I would say all-comer population with 46% of diabetes. In Europe, it's a little less than that, but it's increasing on a regular basis. And I know that in India, it's a real, diabetes is a real, very frequent disaster. We know that those patients with diabetes has an increased risk of cardiovascular events. They have, you see that when this is from the US of, I would say, middle age, but you see that the mortality is much increased, especially when there is also cardiovascular disease. It's a really very bad combination with a poor outcome. The diabetes lead to lesion, coronary lesion, and I would say atherosclerosis in general, but that are more diffuse and more complex. There is an increased necrotic core volume, and this is very well seen in those IVUS images. an increased inflammation and increased calcification. And this lead to a more evolutive disease than other patients, and I would say also more resistant to the treatment that we can propose. So the diabetes increase, when we are speaking of yes, increase not only stenosis, but also the risk of acute and subacute thrombosis. Those two phenomena are due to double reason. One is a delayed healing. That's because endothelialization is slower than on non-diabetic lesion. And there is also an increased inflammatory response. And all that lead to what I said, more less good result with DS. Do we have a better stand than others at the moment? And this is coming from the long-term outcome of a large cohort coming from the northern countries. And you see that for target lesion failure, there is, if you compare to non-diabetic, there is much more target lesion failure described by MACEs. And it's much more than in diabetes. And honestly, even if the Endeavor has a worse outcome than the others are very close to each other, and Endeavor is not anymore on the market. You see also that there is much more stent thrombosis than in non-diabetic patients, with no marked difference. In this series, Xience has a very low rate, but maybe, let's say, we cannot explain because in other series, it's not the case. But you see that in terms of death, which is, the final consequences of all those problems, a diabetic patient with the current generation DS have a worse outcome and with no stent better than the other. Sorry? This is another series from Kyriakis. What you see that, for example, the everolimus eluting stent have better target lesion failure rate in non-diabetic patients, but unfortunately in diabetic, it is the same, and the non-requiring insulin and requiring, of course, the rate is different, but there is no, there was in that series no benefit of the everolimus compared to the paclitaxel. That makes that you know, and I'm sure that Dr. Mehran will speak a lot about comparison between PCI and surgery. That makes that PCI is used for multivessel disease in diabetic patients, but that surgery has really still a role. And if there was in this meta-analysis of all randomized trial PCI versus surgery, there was no difference in death, but the TLF was in favor of surgery. And this illustrates the same. What is the evidence that we have around that is being built about the abluminous stent or device? You see that because of the special design of the device, there is the coating that is all over stent and balloon. We will repeat that many times because that makes really how we expect to get the changes. And you see that thanks to this device, endothelialization is more rapid. The inhibition of proliferation is increased, and there is less thrombus formation. So this was the reason why it was expected that this device would have a better outcome in diabetic patients and was built together with Concept Medical and the team of Mount Sinai, the Ability Diabetes Global Trial. The objective being to have to compare the efficacy and safety of the sirolimus eluting stent versus the albuminous stent in diabetic patients only, with limited inclusion-exclusion criteria. And we think that with this limitation of criteria, exclusion-inclusion, 40% of the patients will be multivessel and at least 30% acute coronary syndrome. As I told you, the device has an abluminal coating of sirolimus that is only of abluminal, and the fusion coating makes that the stent is, the coating is both on the stent and the exposed part of the balloon. And of course, it facilitates much more homogeneous drug delivery that with the current state that have only the drug on the stent itself. And you potentially address also the edge restenosis that we observe in 20% of the cases. And it is a biodegradable film that delivers the drug to the wall, both by the balloon and the stent. The hypothesis of the trial was by providing more drug and greater drug delivery per millimeter square at the vessel wall, we will reduce restenosis in patients with diabetes. The study design is as you see. The patient will be followed during 2 years. It's prospective, multi-center, multinational. We will go all over the world. And the primary endpoint is ID, it's TLF, but also ID-TLR at 1 year, which is powered for non-inferiority, and then sequentially powered for superiority if non-inferiority is met. It's really our objective. We'll go to 100 sites, 20 countries in Europe, Asia, Australia, Latin America, and we plan to enroll 3,000 patients, larger head-to-head comparison stent trial ever designed. And of course, the two stents are the albuminous DES, and the control stent will be the Xience family stent. The patient will be screened for their diabetes, meaning that in the site it will be all-comer diabetes that are eligible for PCI. They will be checked for inclusion-exclusion criteria. If they met, they will go to angiography. If the angiography criteria are validated, they will be then randomized to the albuminous, 1-to-1 to the albuminous or the Xience DES. And the design was done in a way that immediately after the PCI, all the teams are blinded to the treatment. Of course, at the implantation site will not be blinded, but immediately after, even from the report, it will be written study stent. So nobody that will be doing the follow-up will be aware of what treatment was received by the patient. And we want to address all the diabetic, whether they are already known diabetes, orally treated, on diet only, or insulin treated, or newly diagnosed diabetes. They will be also included only on the value of an elevated HbA1c level. And of course, they need to have an asymptomatic coronary artery disease, chronic and non-NST elevation, MI. they need to have at least one stenosis, and there is no limitation of the number of the treated lesion, number of vessel disease or lesion length. We will exclude only the cardiogenic shock and the patient treated for primary PCI for ST elevation. The primary endpoint, I told you, ischemia-driven TLR at 1 year follow-up, powered for non-inferiority and sequentially superiority, and TLF according to ARC2. We have, of course, many secondary endpoints and other composites, and we will also address the bleeding bar2 or more. The management of the trial is with Concept Medical, who is the sponsor of the trial. The Mount Sinai Heart Organization Icahn School of Medicine, which will be in charge with site selection together with us at CERT, all project management, organization of CEC, data management and stats, and CERT in Massy will take care of the site selection also, the submission all over the world. We will work with Mount Sinai on project management, contract with the site, monitoring all the safety and core lab activity for endpoints. And we have this nice team driving this trial under Dr. Roxanne, chairman of the executive committee, and we are extremely proud to work with her. And we have also Prof. Colombo, Prof. Abizaid, and Prof. Saito, that are the three PI. You see international people plus Fadzila Malik, Dr. Idris Smith, Dr. Dudek, Dr. Toll, Dr. Fori, and Dr. Tesla. We have the trial in green are already open. The one in yellow are submission in progress, and the red are submission that will begin soon. And we are at the beginning of the recruitment. Prof. Colombo did the first patient, and we are at near 50 patients. And of course, it's the beginning of a very nice story. And to conclude this talk, dear colleagues, the diabetic population is increasing worldwide. You know that very well, and continue to have a poor outcome despite all medical improvement and technical improvement too. The abluminous device represents the combination of a drug-eluting stent plus a drug-eluting balloon with the advantages of both systems and has the potential to better address this particular high-risk population. And the Abluminous Diabetes Global Trial is the largest head-to-head stent trial for diabetic patients conducted so far. Patients will be recruited in all continents, allowing the conclusion of the trial to be applicable worldwide. And this being said, I thank you a lot. I hope that the connection was not too bad, and I'm ready and be happy to answer your comments and your questions. Thank you.
Marie-Claude, great talk. I really appreciated that your presentation and also everybody's attention, even despite some noise in the background. My question to you is that this is a sirolimus-based stent, right?
Yes, yes,
Right.
it is sirolimus, yes.
Right. And, we have shied away from sirolimus for such a long time. I know that it is coming back outside United States. And within the US, actually, we do not have any sirolimus-based stents as far as I know, except in clinical studies. And do you, yeah. And what are your expectations? Do you think that this is going to be on par with the Xience? Because Xience is now considered as one of the best stents available on the market. Right. So how do you foresee that in your sample size calculations, are you trying to be like non-inferiority, or you're trying also to achieve superiority?
Yes, this is exactly that. As you say, yeah, the Xience is could say the best in class and the reference stent. This is why we decide to compare to this one. And yes, and the idea is to go to non-inferiority, but we really hope that we'll be able to demonstrate superiority. Again, if you could hear it, because the technology is really unique and could address the current limitation that we have with DES in diabetic patients.
Thank you, Dr. Maurice, for your excellent lecture. And we learned a lot, and we are very happy that it is an Indian stent. And we have been using this stent in our labs for the last few months with good results, of course. No untoward reaction has come till now. And we are going to also notice, and we are also going to be the part of the study. And so it's a beautiful one. So as a whole, what should be your tips for dealing with these diabetic patients, irrespective of the stent? How should we treat a diabetic patient for stenting, for any intervention? And regarding selection also, we know about the guidelines, but you know about the real time, as you were mentioning at the initiation of your talk, that it is the Achilles heel. Diabetic and restenosis is a real problem. So in selecting the patients, because now we are seeing that the gap is gradually reducing, and we have got a legend like Dr. Antonio Colombo and Dr. Roxana Meheran and also Ramesh with us. And we know that the recommendations for PCI, suppose in left main lesion, especially in diabetic individuals, is also gradually increasing, and from 2B it's becoming 2A recommendation, or sometimes 1A even. Suppose it is a shaft lesion in left main or osteal lesion, it's becoming a. So what is your tips, or what is your message to the, because many PGTs are also seeing this program. So as a whole, regarding the diabetic patients, what is your tips in dealing with an intervention in diabetic patients?
No, I think that, of course, intervention is important, but I would say the most important, and you know that we are doctors. First, I would say treating correctly the diabetes, having a good correction of the diabetes is the most important. And after, location of the lesion is not so important, because it's more the diffusion of the disease. For me, left main is not an issue. It's a big vessel. If you have a left main alone, you have a very good prognosis. The difficulties and where I would say the limits are, trying to show that they have diabetic patient per lesion. They have a little more restenosis, a little more stent thrombosis. And if you cumulate that with diffuse lesion, 5, 6 stents to a patient, this is where those ones that are not doing well at all, and this is why surgery is doing better in diffuse disease. So I would say that with the current technology available, PCI is good, can be done as long as you are not implanting too many stents. If not, surgeons are doing better for the prognosis of the patient. At least that's my way of treating those patients.
Regarding the choice of antiplatelet agents in this particular trial with this abluminous stent, What is your policy? You are giving clopidogrel or as per the physician's choice, or you have got something like the advanced one, ticagrelor or prasugrel?
No, we leave the physician free of treating. There is no different. We imagine that the antiplatelet treatment will be the same in the two arms. So more potent antiplatelet treatment for the SCS patient, and we know that diabetes patients have more pro-inflammatory and thrombosis, so probably they will have longer term antiplatelet treatment unless they are at high bleeding. But it's the real device head-to-head device trial, so we are not exploring anything in terms of antiplatelet in that trial, just as guideline recommend.
So very good answers, Mary Claude. I just have one more question about diabetes, and Dr. M.K. Das, our CSI president, also saying the same thing, that it is a pan-vascular disease. How can one single stent be enough for the entire diabetes? You answered that. How about other treatments of diabetes, and what is the, how strict of a control are you aiming for diabetes in this population, in this study?
Let's say we recommend to control well, and during follow-up, Dr. Mehran insisted on a lot that we will collect the control of the diabetes during follow-up, and I think that will be also because there will be a large amount of patients. 3,000 is really a lot, and we will explore also if there is a correlation between the evolutivity of the patient and the way their diabetes is controlled or not. And I remember very well when in the trial design that Dr. Mehran insisted a lot on that. Again, we are interventionalists, but also doctors.
Yes.
Sure.
May I ask a question, Ramesh?
Yeah.
Sure. Dr. Datta, you're muted.
Okay, I'll check. So may I ask one question, whether there is a choice of stent for diabetics as of now today, especially in Europe, in France, and also in United States? Dr. Roxana is also here. Is there a particular choice you would like to make as of now, or we start saying that most of these stents are almost same?
No, honestly, and you know that there are many different DS in Europe, but there is no, to my knowledge, there is no better one than the other. So we take the DS that we have on the shelves, I would say, as in non-diabetic patients.
Yeah, in the United States, I mean, even though Resolute Integrity is approved by FDA for diabetics, I don't think that is actually guiding us to choose that stent over the others. I think it is nowadays, most of the stents are coming to very close to each other. So it is a pricing that actually is making an impact on choosing the stents in our hospitals.
Thank you.
Thank you. Very good question, Dr. Chandra. Anybody else? I think we are open for discussion where we have a few more minutes, and I would encourage others to send us questions either by the chat box or you could ask directly.
I just wanted to add to the beautiful talk of Marie Claude, who gave us a fantastic overview of this very exciting trial, which is the largest of its kind in PCI in diabetic patients, taking on the best in class head on as a one-to-one randomization, going for non-inferiority, but really also powered for superiority. Should our theory and our hypothesis be correct with a homogeneous distribution of the drug with the abluminous DES, and if we are correct in our hypothesis, we could show a better result, a reduction of the edge restenosis, the revascularizations that occurs, and we can never win against CABG on those, and hopefully have a best outcome with the best possible background medical therapy, including SGLT1 inhibitors and other things. And I think this is what is really crucial. We have got to take diabetes head on with the best possible device available for these patients. And I think that what we're doing is showing our frustration with the current generation DES and, you know, our failure against bypass surgery, and especially in diabetic patients. So we want to take this head on, and that's why this particular study is of such importance that I'm hoping that the rest of the world wakes up, listens to this. All of our sites will enroll with great might and with great quality, because if this is right, we can really have a win in diabetic patients. And all we care about, Marie-Claude and I, is to make sure we get the best therapy to our patients. And that's where we're at. We could lose, but we need to keep trying. And I believe that this particular, we don't have this technology here. All we have are, you know, Synergy, Onyx, Xience. And they've done great, but, you know, against diabetes, with diabetic patients, we've not been as effective. And we want to get very low in the single digit numbers for target lesion revascularization in this patient population, despite the diffuseness nature of the disease. And so that's really why we designed this study and worked very, very hard. And you should all be very proud, because this is an Indian stent. And so a great opportunity to put India on the map as an innovative place where we could actually have, and whoever is out there listening, this is really very unique technology, innovative technology, and the company is a small one. So support them. Make sure that we actually get after this important issue. And what we're doing is blinding the investigators to the follow-up, because we don't want any bias. Even ourselves, we're not going to be a part of any of that, independent CEC, etc. So, you know, we're hoping that all of this takes place, and we're very, very excited about it.
Yeah, Dr. Roxana, very nice comments about this Indian stent. And let me tell you that we earlier did the Tuxedo trial, which was Xience versus the Taxis stents at that time, which was in diabetic patients. And now we have embarked on a new trial, which is the Tuxedo 2 trial, where we are comparing the Xience stent and another Indian stent, which is made in India, and it is it's a sirolimus eluting stent, and it's from Sajan and Medical Technology. So we are doing a head-on trial, a head-to-head comparison in 2,000 patients, and we will have the results in another maybe a year.
Good for you. Good for you. Well, we've got 3,000. There you go.
Okay. Thank you.
So, Madam Mehran, thank you for your very good comments. How you are going to follow up these patients? And what should be the protocol of?
No, we don't want to.
That's very important. Like Tuxedo 1, which was also published in NEJM, and I, Praveen, all were part of that study as well. We compared Xience with Taxus, and we had just a clinical follow-up. You know, by sometimes even the patient cannot come. We had a telephonic interview of the patient. We asked some questions, and we have written them up. Now we are having Tuxedo 2, where Xience is the benchmark stent, and we are comparing it with a Supraflex Cruise stent, which is a sirolimus eluting stent again with 2,000 patients. So we are our follow-up is very simple, because we want to learn that how you are going to follow up these patients.
Well, I'll discuss it with you, and I think Dr. Marie-Claude already did show that We will be having 100% follow-up. We will not lose a single patient. Vital status on everyone, adherence to their medication and evaluation of their background medical therapy on everyone, with visits as much as we can, and follow-ups, telephone follow-ups as well. Just like we did in Twilight, we lost hardly any patients. We will be very vigilant in making sure that we have full follow-up. We do not want a angiographic evaluation because those are very biased and drives people to do things that are unnecessary. So we are doing a very real world diabetic patient, an all-comer diabetic patient, very few exclusions as you saw. So we're very excited about the trial.
And you are going to put almost all the patients on SGLT2 inhibitors and metformin?
No, I mean, we can't do that where we don't have those kinds of funding. This is a tiny company. We can't, but we are really sending a lot of, guidelines to the sites to treat the glucose, to make sure that the hemoglobin A1C is certainly less than 7. And working hard to achieve that with whatever way they are choosing to do so.
Okay, any more question?
So I'm happy to
Any more question? You have got the legion. Yeah.
If that works
Dr.
for you
Dotto,
guys.
Professor Anjan Dotto. So I think there are no more questions also. Ramesh, there is no question in the chat box also?
No questions in the chat box. Doctor.
Yeah. So any comments from you, Ramesh, or Dr. Roy, Devabrata Roy? Yeah, Praveen?
Yeah, I think this was a wonderful discussion and presentation, and we are glad that, the two big, trials are ongoing, and with the use of these Indian stents, and with so many diabetic patients in India, we ought to do this, and certainly we'll have the results very soon. And as Dr. Roxana said, that we have to conquer this problem, which is still hanging, and we don't have the final answer as to how we compete with surgery.
Yeah. Okay.
We lost Praveen, I think, but
lost Praveen. Yeah.
We could go ahead and introduce Dr. Mehran.
Anyhow, that was a very good discussion, and thank you, Professor Morris and Professor Roxana Mehran. And as Dr. Colombo is busy and he is caught up in an emergency and not sure about his time of joining, I would invite our respected speaker, Dr. Roxana Mehran, who is the Mount Sinai Professor of Cardiovascular Clinical Research and Outcomes and Professor of Medicine and Population Health Science and Policy, Director of Interventional Cardiovascular Research and Clinical Trial, Ishan School of Medicine at Mount Sinai, New York. And he is the innovator and PI of many trials, and we all of us know her very well. And I think she doesn't need any introduction to the Indian cardiology. So Dr. Mehran, kindly start your speech, please. Thank you.
Thank you, Dr. Kahali. Ladies and gentlemen, my esteemed colleagues on this wonderful symposium, and from the Indian Society of Cardiology. And thank you for including such a tough topic, especially given that the Freedom Trial was run by my boss, my mentor, and somebody that I respect tremendously. And I worked very hard on the Freedom Trial. But I think it's good for us to kind of discuss where we are today and how far are we from freeing ourselves from freedom, right? I mean, I think that's really where we are. I think it's important for you to note my disclosures, but most importantly that I am working very closely with Professor Marie-Claude Maurice and our co-PIs and our PIs of the of the ability to DM study, Dr. Colombo and Dr. Abajide, and that I am the chair of the study. It's no surprise that coronary artery disease in diabetic patients is increasing across the globe, especially in our country, but importantly in where you all are in India. 15% of adult population have diabetes, and 55% of diabetic patients have coronary disease. And we're starting to see a younger age of onset of coronary disease in diabetic patients. Women affected importantly and in the same way as men. And in fact, women with diabetes presenting younger with so much more comorbidities than men and so much higher events than our male colleagues. And very, very importantly, showing that we have a tremendous amount of work to do in our diabetic patient population. If you look at the prevalence and you start to see where you're going in the darker colors, and India is lighting up in the darkest colors, up to 50–60% of the CAD prevalence in diabetic patients, you can see that it is a pretty important situation, and it's increasing over time. It's also important to note that when coronary disease presents itself in our diabetic patients, you see more severe diffuse coronary disease in smaller vessels with autonomic dysfunction presenting as silent ischemia with ventricular dilation and dysfunction. We're working on a diabetic cardiomyopathy drug right now. 2 to 4-fold higher morbidity mortality rates in our diabetic patients, and the cause of death in 60% of the diabetic patients being cardiovascular disease. The interplay of the pathologic processes in diabetes make it extremely difficult for us to prevent this important complication of cardiovascular disease in diabetic patients. The progression and worsening of coronary disease has multitudes of areas for us to focus on, including inflammation, prothrombotic state, important atherosclerotic burden that's massive in these patients with a very aggressive intimal hyperplasia, endothelial dysfunction, and then the important cardiorenal pathway where we see renal and cardiovascular disease coming together with LV dysfunction as well. The evidence from the randomized trial for the best revascularization strategies in diabetic patients have been put forth, and CABG continues to reign supreme. Here's the Berry trial. Early on, you see the separation of the curves of CABG versus PCI with a much worse outcomes in diabetic patients in Berry. And the Berry 2D registry, where we're looking at CABG or PCI, any revascularization versus medical therapy, take a look and see how difficult it is, especially you see these higher MACE rates and higher syntax score. And very important that we're seeing an issue with PCI. The evidence from the large randomized studies, and if we look at the syntax trial and diabetic patients, the PCI strategy is associated with a higher risk of target lesion revascularization, higher mortality, and higher risks of major adverse cerebral and cardiovascular events in our diabetic patients. Take a look at the numbers. At 5 years, the event rates so much higher in diabetic patients for TLR, death, and major adverse cardiovascular and cerebrovascular studies. And can we use the syntax score to actually help us identify the best choice in diabetic patients? And here's the diabetic versus non-diabetic patients really showing an incredible negative result with patients with a high syntax score and maybe some parity in the lower syntax score patients and diabetes. But we have the largest trial in diabetic patients, focused in diabetic patients with 3,300 patients, and finally randomizing about 1,000 in each arm, 1,900 patients enrolled, 140 sites. And this was a very major study in diabetic patients. It is important to note that the drug-eluting stents used were Cypher and Taxus, no longer used anywhere. But still, very important issue to see that these diabetic patients had very high glycosylated hemoglobin at baseline. They were current smokers, previous MI, a lot higher. You can see the very high level of 3-vessel disease, 84%, and a very important number of patients also with low ejection fraction. If you look at the syntax score as a whole, it was 26, the mean syntax score. And the high syntax score was really not that high. I mean, it was 19-20%. The majority of the patients actually had low to intermediate syntax score. Nonetheless, the very important endpoint of death, MI, and stroke, major adverse cardiovascular events, were in favor of CABG, especially as we go into the 5th year. You start the separation of the curves beyond 2 years in favor of CABG. Higher rate of revascularization for these patients, but a very important study that is really in our face, because the syntax score did not make a difference in this particular trial. No matter what the syntax score, the patients did better with CABG. The follow-on study remained consistent with an extended follow-up for a large number of sites. And here, in patients with diabetes and multivessel disease, CABG led to a much lower all-cause mortality compared to DES in the longer term, up to 8 years of follow-up. Again, seeing the separation of the curves beginning at 2 years and continuing separation for probability of the most important thing we're looking to avoid, and that is death. Probability of survival was better for CABG. And it was independent of the syntax score and independent of insulin-treated diabetes. No interaction of these two important variables that we would assume would really change the course of therapy for patients where we previously thought through the syntax study. So what did we learn, and what's still valid in Freedom? What we found very importantly is how important is guideline-based medical therapy and optimal control of the risk factors. We didn't do a very good job in Freedom. Despite all of the efforts in a clinical trial that was controlled by the NIH and the investigators, we still did not reach goal in the majority of the patients in their use of beta blockers, control of hypertension, control of all of their important guideline-based medical management. We also found that in diabetic patients, dual antiplatelet therapy was very much there for 12 months of DAPT for these patients after PCI with aspirin and clopidogrel. I wonder if this is still valid, and this is what we're doing. And we also learned that very important use of arterial grafts could make an important impact for bypass surgery. But where are we today? The compliance and goals were not reached in Freedom. The use of early generation DES with prolonged DAPT is what was needed for them. Can we overcome, and can we go to a shorter duration to avoid the bleeding that could lead to a higher mortality? And we now have new hypoglycemic agents. The SGLT2 inhibitors reduce myocardial infarction and mortality, cardiovascular hard endpoints, and may impact these newer recommendations. And we know that stent thrombosis with early generation DES was the Achilles heel for this drug-eluting stent family that was included in the Freedom trial. And we absolutely must overcome this. And now comparing the early versus the next generation DES with thinner struts, better metal alloy, biocompatible or degradable polymers with adequate drug kinetics, we should have an enhanced outcome. And we haven't had the chance to actually go up against bypass in diabetic patients in larger numbers of patients. And in fact, we're making a better outcome, improving performance, improving our techniques with intravascular imaging, much better antiplatelet regimens, and innovative approaches like a P2Y12 monotherapy that we used in Twilight for antiplatelet efficacy and prevention strategies. And we're very smart that when we move forward with these next generation stents, and when some bump comes in the road, we push it out of the way, which is the bioresorbable scaffolds. We're pushing forward and making sure that the best therapies are available for our patients. We're improving our techniques. And if we use IVUS and OCT, we will get better results. It's so important in diffusely diseased small vessels to get best possible results with your stent. And you only can do this by reducing TLR, stent thrombosis, and MACE if you use best techniques, optimal results with IVUS and OCT. And here's a very important large meta-analysis showing less malapposition under expansion, resulting in better outcomes. And the next generation DES is being tested in a lot of studies. And of course, I would remiss not to present the Tuxedo trial in the New England Journal of Medicine. Diabetic patients, stable angina, randomized to everolimus-eluting stents versus paclitaxel-eluting stent, showing the exact benefit of the everolimus-eluting stent in reducing target vessel failure and ischemia-driven target lesion revascularization in a tremendous fashion. Congratulations to the Tuxedo investigators in India who did this study and showed this beautifully in our diabetic patients. But we now have new DES technology that has been made for diabetic patients. The Abluminous DES is designed for this difficult patient population. It carries the drug on the abluminal surface of the stent and the exposed parts of the balloon, as well as the 0.5 millimeters of the balloon in the distal edge. What are you getting? A homogeneous distribution of the drug across the diseased artery and its entire segment, leading, hopefully, to a much better reendothelialization with a biodegradable polymer matrix and sirolimus as a drug that has worked beautifully in previous past. This randomized, largest ever clinical trial to take on the best in class everolimus-eluting stent Xience in diabetic patients is prospective, multi-center, multinational, completely controlled, open label, 2-arm parallel groups over a 54-month period where we are looking at target lesion failure powered for non-inferiority, ischemia-driven TLR at 1 year, powered for non-inferiority and sequential superiority with very important secondary endpoints, tackling the entire diabetic patient as a whole. We're doing this work. Mount Sinai, the Icahn School of Medicine, is absolutely proud to work with the best in-class ARO, CRO, CERC, the Cardiovascular European Research Center led by Marie-Claude Maurice. It has been the best possible partnership to date for me. I'm so proud to work with a legend in interventional cardiology, Professor Marie-Claude Maurice. And these two women, myself and Marie-Claude Maurice, will bring this trial to its completion with the highest quality ever in a PCI trial to date, especially in our diabetic patients. In a one-to-one randomized study, we will randomize the abluminous stent DES compared to the PCI with everolimus-eluting stent, the Zion stent. Let's not forget that there are also other important studies that are going on, and there will be many, many more, and you just told us about Tuxedo 2, but the CREATE trial is also going after an important, the BioFreedom BES, looking for an ability to kind of come across to this diabetic patient population. Innovative designs are being made. Let us be kept on our toes. I love that industry is competing with each other for the best possible results in our patients. It's so important. Diabetic patients really do not do well with the status quo. We need to do better. So in conclusion, the FREEDOM trial and the FREEDOM follow-on trial showed a bad result for PCI. But recent advances and performances in PCI performance and therapeutics and the current generation or innovative approaches, especially with the abluminous, and you're testing the Talent stent, I think, in the in this patient population. It is foolish to ignore the results of FREEDOM and the FREEDOM trials. And it's equally foolish to ignore the wealth of data supporting the clear impact on death and MI with improvements of our medical therapies and technologies. This is what Shripal Bangalore wrote in his beautiful editorial in JACC 2019. And we are ready in interventional cardiology to always tackle the worst and most difficult patients with our lesser invasive approaches using catheter-based technologies to approach and treat patients with cardiovascular disease, especially those with diabetes, to get the best possible outcome with the least burden to that patient in the least invasive way possible. And for that, I thank you for your attention, for having me in this meeting. Thank you so much.
Thank you, Dr. Roxana Mehran, for your wonderful speech. And you have shown a global view what happens in the diabetic population, PCI versus CABG. And really, we are losing the game. The interventionists and surgeons are winning, and everything is in favor of CABG till now. But we are going forward to find some solution. As you mentioned, we are going for some innovative technology to beat this deficiency on our part as interventional cardiologists. So there is a question, madam, just in following the Maury Claude Maris madam's presentation, that have you used it in non-diabetic patients also? Or secondly, have you got any proposal to have this abluminous coating with everolimus-eluting stent also? Means instead of sirolimus, everolimus molecule. So these are the two questions to you.
I don't think there is, I don't know of any, I'm not so sure what the question is, but honestly, we don't have this stents, these innovative technologies available to us in the United States. I told you that the only stents we use are Onyx, which has done great, Zions, which is amazingly a fantastic platform, Synergy stent, which is also, and Promise. These are all wonderful, wonderful stents that have really, really reduced the ischemic outcomes. But we have to continue to push hard, you know, especially after Excel, when we saw higher mortality in PCI over a period of time, over a long period of time. And while it was absolutely probably a play of chance, and we're not powered for that endpoint, we have to keep putting our feet to the fire to do better, to bring the best possible results. And we cannot get away from the diabetic patients who have very different biology, very different processes. And it's not just about a stent. They continue to have more new lesions outside of the stent that keeps the cabbage in the right place. But maybe if we are smart to kind of work with our patients and spend a little bit more time than just quickly putting in a stent and getting out, is actually taking that patient and marrying that patient to the best optimal medical management, to tell them that if they don't do this, they will end up with bypass. And if they don't stop smoking, and if they don't continue to worry about their waist circumference and getting that hemoglobin A1C under 7, they will end up with the knife.
Yeah.
And that we should be sending those people away to get bypass, because it won't work. PCI will not work without best optimal medical management. So let's make sure we bring those events down so that we could go up against bypass. We will never win against bypass if we don't take care of the entire biology of the diabetic patient with best optimal medical management.
And also, madam, surgeons are ahead of us because of an anatomical superiority with the surgeons, that they give the graft little distally and they deal with the future lesions.
They deal with the entire vessel.
Yeah.
They protect the vessel.
Yeah.
So if you want the lesser invasive management, your medical management has to be really, really high up there. SGLT2 inhibitors, controlling hypertension. The glucose has to be under, you know, taking care of the insulin resistance in these patients. And it's the metabolic syndrome patients too. It's really the same thing. So if we don't get around our arms around that, we're never going to win.
A great talk, actually. We enjoyed listening to you about the freedom and how we can push beyond freedom. And I know most of the times actually we try to take randomized controlled trials, but in my own experience and in United States, you have the huge multi-vessel disease in diabetes are the ones surgically turned down. And in those cases, we try to do the best with PCI, and as you said rightly, using FFR and OCT or IVUS, I think will change the outcomes in diabetes with coronary artery disease. One more question from Dr. M.K. Das is that will adding colchicine change the scenario in diabetic population?
I mean, your voice came over, but I'm so sorry. You were a little bit muffled. Let me make sure I understand. You're saying about the patients who are turned down, right? Is that the diabetic patients who cabbage is turned down, and well, it doesn't matter. I think no matter what, when you're doing PCI, you need to be, as Marie-Claude said, we are not just monkeys in a lab. We are also doctors. We are not just proceduralists. We are doctors. Yeah. We need to take care of the patient. And the patient and their biology, you take care of this. The stent takes care of the end point of that biology, which is a tight lesion. But there's more lesions coming. There's many more coming. If you want to prevent those coming and turning into myocardial infarction, death, sudden cardiac death, then we better get our arms around the medical management of these patients. Otherwise, then, send them to cabbage, they still will die. They still die more often because if you don't do optimal medical management to these patients. And I'm really serious that this is really an incredible, I can't even believe that we believe we're great if we just put a stent in and because we have new technology, we've solved everything. We haven't solved anything if we don't solve the biology of these patients and change the trajectory. And the only way you're going to change the trajectory is not by putting a full metal jacket. It's by treating them medically and changing the biology, reducing the inflammation, reducing the fat deposits that are causing more inflammation, taking care of the insulin resistance, understanding how to go after this. I mean, some of the very obese patients need to have important surgeries to reduce their adiposity by, even some of the very severely obese patients who are diabetics. We have to be looking at this in a very, very big metabolic way in marriage with our best technologies to keep the patient in a lesser invasive path. Nobody wants to go to surgery. Nobody wants their chest cracked and put on some artificial machine that is absolutely not making anyone smarter. We come out less smart after bypass. It's something small, but it's there. So if we want the lesser invasive treatments to reign supreme, we better understand how to take care of the biology of this patient with diabetes. Understand what is happening with all of your food. What are you doing with ghee in every one of your food? It's delicious. I love Indian food, but there has to be a better way to reduce the carbohydrate intake, to reduce and to really educate your people and our people in the United States. We stopped soda machines. We're working very, very hard to reduce. Diabetes is a massive epidemic in the United States, the size of something we cannot ever imagine that our healthcare dollars will not be able to pay for these people going forward, especially with a pandemic in front of us. So we have to work really hard. And I think you guys could teach us, and we should work together and think about that and work with these companies that have the SGLT2 inhibitors in such a ridiculous cost that we can't make it available. But you know what? There's metformin. There's all these other very important drugs that are going to go into a generic form that you should be applying and should be following those patients. Make time for your patients. If they're going to come to the lesser invasive path, you have to work with the biology. It will never work.
Very good, Roxana. Also, one more question from Dr. M.K. Das is about colchicine. Do you think colchicine will have any role in multivessel disease, PCI, and diabetics?
Yeah, I mean, I think these cheaper therapies, you know, I think, as I said, if we you know, in high inflammation, any of this colchicine is a very, very cheap drug. I know that people don't want to keep taking drugs. One of the reasons why people love to go to PCI and cabbage is they feel like they can take less anti-anginals, and all those things happen. PCI does that. Revascularization does that. And then it makes room for other things that actually work, right? Stop the anti-anginals and move towards the change of biology, reducing inflammation, reducing hemoglobin A1C, diet, exercise, stopping smoking, all of those important variables and the change in the diet. So yes, I agree that colchicine, but we haven't seen a diabetes study, but it's a no-brainer, right? Cheap, easy, available drug.
Right, absolutely.
Thank you, Dr. Mehran, for your excellent comments. And I really appreciate your comments, because we only treat the lesion, you know, but we should treat the human being as a whole. And we have to have an eye on all the parameters like lipids, you know. Just I was going through a paper this morning that after PCI, if lipids are controlled in a good way and sufficient way, the results are much, much better. So that's very important. Just by reducing weight by 5 to 6 kgs, one can reduce the blood sugar by 7 to 10%. So these are very important things. And I really appreciate your comments that we should not deal only with the arteries, but only with or the lesions, but we should deal with the person as a whole. That's very valid. And we have to give some time to the patient also. Thank you very much for your valid comments. Any question, Ramesh, in the chat box?
Yeah, I ask one question of Kali.
Yeah.
Yes, Dr. Chandra.
Yeah. Please, please.
So,
Hi, Dr. Chandra. Nice to see you, Dr.
Yeah,
Chandra.
Nice seeing you too. So this was a wonderful presentation, and I must congratulate you for making this point that we have to treat the patient and not the lesion. So that's wonderful, and that's what we should do. So now one question is that, you know, in the trial which you're going to do, and the lesions which are being taken up, are they real diabetic lesions? For example, diabetic, the main challenge is the long lesions, small vessels, and diffuse disease. So are we taking these kind of patients in this study, or we are excluding them?
No, we're not excluding them. We're including them. I mean, we're not taking a 2.2 millimeter or 2.0 millimeter vessel. That patient would do much better with just medical management. You shouldn't be stenting these small vessels and putting full metal jackets. what we're taking on are the kinds of lesions that have not done well with the current generation DES, even with the best possible, best in class. And I think with this more homogeneous, this really innovative, wonderful technology by Indian engineers and an Indian company that has put a lot of time and effort into actually doing this, you know, you should be very, very proud, very, very proud of Concept Medical for what they've done. They're so small and they're making huge impact in the world. And I think, you know, and I hope that you're all very supportive of this company because it's very easy to go to the bigger company and feel excited to work with a bigger sponsor. But it's also really, really important to recognize that small but making big impact, just like Ruth Bader Ginsburg, tiny but mighty. That is what we say. You know, we had a big loss last night in the United States Supreme Court by losing our most wonderful, wonderful Chief Justice Ruth Bader Ginsburg. We're mourning her loss, but remembering that small can make big impact. And here's a small company, Concept Medical, making a very big impact across the globe, coming out furiously with a 3,000 patient study. You know, they really are working very, very hard. So please support them. Don't compete, support. Support this Indian company. They're working hard.
Certainly we will.
Okay.
Roxanne, I think lots of questions coming out, and I'll try to answer.
I'm sure.
Yeah.
Can I?
So, do you think you'll be presenting this at the US FDA, the data from, and how is that even going to help?
What do you think?
Yeah, I think we should, right? Yeah, absolutely.
Yeah.
Dr. Ghosh has a question. Dr. Ghosh?
Okay, it is a nice updating knowledge of us. So day by day, with the development of technology and development of treatment, more and more patients treated with PCI than CABG going to have a better result. Till now, what knowledge we have, can we take all patients for CABG and blindly PCI? Or would you suggest for which patient would you let the ball keep for the surgeon? Give me, can you have a suggestion or advice for us, please?
I mean, I think for me, my approach to my diabetic patient, as soon as that we see multivessel disease and diabetics, we take that patient off the table. We don't do ad hoc PCI on any diabetic patient with multivessel disease. We then talk with the patient. We talk to them about their risk factors. We talk to them about the risk of surgery. And we bring the surgeon and the interventionalist in the same room together, not separate, because if the interventionalist talks alone to the patient and says, well, you could get, you know, they crack your chest open, they put you on a machine, it sounds awful. I would be like, oh, no, I'll have PCI, right? It's like saying to you, you can have a beautiful, gorgeous gourmet meal, or you get some bread and water. Which one do you want to choose? Of course, you're going to go with the other one, right? So I think it's very, very important that we have a heart team approach to diabetic patients with multivessel disease, which was put forth by the syntax investigators, Professor Sorois, Ari Peter Capitan, Professor Marie-Claude Maurice. They came up with the heart team. So the heart team is crucial for diabetic patients. There's not everything, one size does not fit all. And it's not cabbage for all or PCI for all. It's a discussion. And the patient is the most important part of this discussion. The patient has to make a choice, a valid choice, be given the data in a way that that patient understands it. We cannot assume that our patients are not smart to understand. And you as a physician and the heart team member have to get to know that patient better to understand what is best for that patient. If the patient can't comply with dual antiplatelet therapies and medications that are going to be extremely, extremely hard on them, like all of the multitudes of medicines, if there's compliance with medication, if they need healthcare providers to help them or You know, they have people at home that are helping with their medicines, or they're alone and they don't have support and they can't afford it. I think you have to tell them that a better approach for you would be bypass surgery. If a patient is motivated, if the patient has a lesion that's approachable by syntax score less than 33, with a very, very good ability to reach ability, DM, you know, just like our trial. If you have the, you're honest with yourself, your patient, and engage them. Patient engagement is so massively important. We don't do enough of it. You can really conquer and get to great ways. Now, we haven't shown this in a prospective randomized trial. So first, we're going to say, what's the best possible PCI technique for these patients? It's going to be with IVUS OCT, best possible result, treating the most important lesions, using FFR-guided PCI, all those things. Once you decide to do PCI, you better do the best possible job and work very, very hard with the best optimal medical management. And it's a good number of patients who fit that category. And right now we're working to see what's the best possible stent for these patients. And we think we have it, but we haven't proven it. That's why enrolling in our trial is going to be really, really important. I hope I answered your question.
Can I ask Dr. Mehran that if the syntax score is more than 33, what are the situation apart from the fact that the patient is frail and she is not fit or she is not fit for the CABG procedure? What are the other situations where the syntax score is more than 33?
I mean, there are very, you know, it's such an important question, Dr. Kahali, because in the high syntax score patients, we also have terrible distal targets. And is it really worth to put a frail COPD, STS score, high STS score patient under the knife if they're really, all they're asking for is less angina, a better quality of life? Can I just be, you know, a more better controlled? Of course, then in those cases, using, again, a very, very high level PCI, not stenting every lesion, understanding what is the best possible couplet vessel, and dealing with a stenting procedure that would relieve their symptoms, improve the quality of their life, should be the focus. I mean, I think it changes from patient to patient. But even in those patients with the worst possible results, if we don't do the best optimal medical management, we still didn't do that patient any favor by doing PCI in their worst lesion, for example. We still have to work with that patient. Those are the most difficult patients. Yeah. Unfortunately, in our current healthcare milieu, we just have, doctors have less and less time with patients. So you have to mobilize your team, your nurse practitioners, your nurses, to really follow up with these patients, educate them, give them the best possible medical management. And I think those are the kinds of things we're going to have to do in order to really, really get our arms around this important epidemic that you're facing in India.
And especially with the advent of FFR, you know, we can minimize the number of lesions, what we see as, you know, yeah. So we could, and there is a question for you, madam, from Dr. Kajal Ganguly, that in such diabetic patients, in what percentage of patients you use the imaging? And what is the choice of your image, more of IVUS or more of OCT?
Well, we do both IVUS and OCT. You know that I come from a very, very high volume cath lab with a lot of patients, with the best two operators, two Indian best operators in the world, Dr. Kinney and Dr. Sharma. I work under their incredible, amazing expertise. I was trained by Dr. Sharma, and I have worked with him, and I've watched his beautiful, beautiful technique. He uses in calcific lesions, rotational atherectomy, or some plaque modification technique to get the best possible expansion of the stent. When in doubt, he will use intravascular ultrasound or OCT, depending on what's there. I mean, the expertise are tremendous. my advice to everyone is to use the technique that you are familiar with. It doesn't make sense to use OCT if you can't even understand what those images look like. Make sure you familiarize yourself with one imaging technology that you will use expeditiously and in a very highest quality, and then working closely and like not increasing your stenting, but optimizing your stent outcomes and your stent procedure and technique by using those, and then incorporating physiology in your evaluation of what should not be treated, not what should be treated, but what should not be treated, to minimize the number of stents, because we know that exposing these patients to lifetime dual antiplatelet therapy, even with the potent agents, and now we have innovative ways to just give ticagrelor monotherapy to these patients. You saw the Twilight diabetes data, incredibly, incredibly, incredibly important to see that we could actually give ticagrelor monotherapy and reduce bleeding without changing ischemic events and reduce that to a very low level. You are able to do those kinds of things in a very, very good way.
Thank you, madam. Dr. Colombo is expected any moment, and he is a little late because of an emergency, and he has told about 20 minutes back that within 15 to 20 minutes he will be available. So we are expecting him any moment.
Okay,
so
that sounds
till then,
great.
any questions? Any questions, Dr. Ramesh?
Yes,
I want to make sure you understand I have a hard out at exactly 12 minutes. I have to be out on another conflict. I'm very sorry.
Yes. Wonderful,
Okay,
Roxana.
okay.
So quickly, let me ask you a question from the audience. Is about a hybrid procedures. So Lima to LAD and PCI to all the other vessels in diabetes.
Yeah,
What
it's a
is
very,
your-
very good, it's a great possibility. We tried to do a hybrid study, as you know. Mount Sinai was the head of the cardiothoracic network, the CTSN network from Cardiothoracic Surgery Network from NIH. The hybrid trial was underway, but it was stopped due to low enrollment, and it was of concern because I don't think people are ready for a hybrid. It's sad, right? Because imagine you can really get the heart team together, give the best lifeline to the patient with the Lima to the LAD, and take care of the other, because you only have one Lima. I think that we're better than vein grafts. Our current generation DES is probably better than a vein graft. And it would be great. It just makes sense. I remember 20 years ago talking about this when we didn't even have drug-eluting stents. With bare stents, we were talking about a hybrid work when I was in the Washington Hospital Center. And there was this ability to do minimally invasive on-pump, off-pump cabbage with the Lima to the LAD, mid-cab. Unfortunately, none of that has taken off because we haven't been able to play in the same sandbox together, and we should. And we should have been, all of us, turning our multi-vessel patients and enrolling in this nationwide study, and we didn't. So this is the price we pay for it. We are not doing a hybrid study at the moment. So we'll never know the answer.
May I add here about the hybrid procedures in India. So we did a number of these procedures where Lima was given to the LAD through a lateral thoracic incision, and also some patients we did with a robotic Lima. And at the same time, because this started when we had this hybrid cath lab. So in the same lab, we did the robotic Lima, and once the procedure was over, we gave dual antiplatelet therapy through the Riles tube, and then checked the Lima on the table, and then did the RCA or the circumflex at the same time. So we did this, it is very feasible. The only issue was that the cost became almost double. So that was the biggest limitation for most of us, and that's how we could not take it too much in too many patients.
Yeah, absolutely.
Dr. Mehran, yeah, there is a question for you that what is your experience and what is your recommendation regarding the drug-eluting balloons, sirolimus-eluting balloons, especially in diabetic small vessel disease?
Well, we don't have drug-coated balloons, so I can't use them. You know, we're very limited, but it's a great idea. As you know, Concept Medical has this wonderful sirolimus eluting balloon with nanotechnology, and they've done such beautiful work there. And I'm hoping that their trial is going to come forth, especially in small vessel disease, as a de novo and a alternative to stenting small vessels. So I'm hoping that we will be smart enough to bring this into the United States and examine it and do the right high level quality, high quality randomized study. And I think it's happening. Certainly in ISR, I think it's a must. We don't want multiple layers of stents inside other stents sandwiched in. The club sandwich, there is just so much room there. And of course, we also would like to see this in de novo small vessels, but we don't have it available in the US.
Thank you.
We're behind you guys.
Ramesh, you were telling something.
No, I think one more question from Dr. Sinha is that in primary PCI with multi-vessel disease, LAD being the culprit, is still CABG procedure of choice? I mean, I think many people shy away from CABG, especially the surgeons, in the setting of an acute MI. So I don't think in those kind of populations.
I think in the setting of a STEMI, I think in the setting of STEMI, revascularization, complete revascularization is the key element, most important. As you know, we did this work with the complete trial in STEMI patients and showed reduction of death and MI, tremendous reduction of death and MI with routine complete revascularization. The method of revascularization in those patients was predominantly PCI to the non-culprit vessel. And really, there's very little to no data. And I can't imagine that in the throes of a STEMI, you're going to treat the culprit vessel, the LAD, and you now are going to send the patient for CABG when your LAD has already been treated. That just makes no sense whatsoever. The only reason I would send a patient to CABG ever is for a lima to the LAD. That is the reason for CABG. That's why they win, because they have lima is an incredibly effective treatment to bypass the most important vessel, which is the LAD. And so if you don't have a good distal target and you're not dealing with an LAD, why are you sending the patient to CABG?
And especially if the LAD is 100% occluded, we have to open it at any cost then and there. Of course, if it is a TME3 flow or good flow, then of course in a multi-vessel disease, sometimes we can think of, CABG later on. But the infarct-related artery, always go for the procedure. And now as it is told that in case of MI, if possible, we should go for revascularizing all the lesions in the same admission, even on the same sitting, even if it is not possible.
Well, I don't know about the same sitting. We didn't examine that. There's no data that shows the same sitting is the best possible way.
Yeah.
I just think that it needs to be done in, what we did in Complete did not answer is the only largest randomized trial on this. All the others are underpowered. What we showed is that if you do the revascularization in the hospital or after the hospitalization within the 45 days, it doesn't matter when, even if you waited 45 days and did it, or in the same hospitalization, not in the same setting, you had a better outcome than not doing anything. The same setting during acute PCI, I think that is a very big clinical judgment on the physician. If you have if you don't know what your culprit is and you have two really big vessels and they're both easy to do, I guess I understand it. But if you can, it's better to just finish the procedure, let the patient reperfuse in the culprit vessel. Before sending him home, you can do a radial procedure and quickly take care of the non-culprit vessel, or send them home and bring them back in 45 days, within 45 days, to do the complete revascularization. That's what we showed in the complete trial.
Yeah.
In
Roxanne,
India,
I know
madam, of course, we have been, we have been doing, suppose he has got a LED-related MI, and the circulation is a tight one, very tight one, and the patient is hemodynamically stable. We would have done both the things in the same sitting with good results because of financial reasons. Because going for another sitting means another angioplasty cost. So to reduce that economic burden on the patient, we frequently went for two vessels together, provided the patient was stable, with good results, of course. Yeah.
Great.
Yes, Ramesh, you were talking something.
No, I know Roxana has to leave in 3 minutes. Dr. Machant
Thank
has
you,
asked,
Robert.
STEMI with abluminous, what's your opinion?
STEMI with what?
The abluminal stent with from
Oh,
Concept Medical.
I haven't seen the data, I'm sure. I mean, I don't understand why it wouldn't be. I mean, this is a really good stent. It delivers beautifully. I think it should do extremely well. The data that they currently have shown with their real world registry looks beautiful. I mean, I don't have any concerns about this stent. That's why we're going up against the most complex patients, diabetic patients.
Right. So thank you very much, Roxana, and I think Dr.
Thank
Kahali.
you, Dr. Dukabadi. Thank you so much.
Thank you very much, Dr. Roxana Meheran from Cardiological Society of India. Yeah. And thank you very much for your wonderful speech. Yeah, thank you.
Really nice to see you all. Have a great rest of the day. I know you don't do weekends, you work on Saturdays.
And we'll meet very soon virtually again. Hoping to see you again. Wonderful speech. Congratulations. And yeah, thank you. Yeah, sure.
PCT Connect. Don't forget, India is very important for us.
Yes.
Yeah, we have already recorded one in TCT Connect. Thank you, madam. Thank you. Great speech. Thank you. Thank you, madam. So, Ramesh, Dr. Antonio Colombo has sent a message just now because he was trying to come and he told that he will be joining within minutes, but he is stuck with an emergency and he cannot come out of it. So, he will not be able to join the meeting. So, I think we have finished the talk on this diabetic patients, abluminous and freedom trial, all this. And we have another versatile speaker, Dr. Praveen Chandra with us, and I would request if you allow, of course, now, or if you want to discuss something more, and then we'll request. But I think we can request Dr. Praveen Chandra to deliver his speech on is there any alternative to FFR, and also, of course, telling that what are the benefits of FFR. So as a whole, telling about the status. So Praveen, please.
Very good. Thank you.
Thank you, Dr. Kahali and Ramesh and all my colleagues here. So it is my pleasure to be here this evening with you all and share with you the information which we have, especially when we have seen two big trials being released and presented very recently. So I think on that background, this is the talk that whether we need an alternative to FFR or not. So I'm sure most of us agree that FFR is a useful technology, and I got hooked onto it about 10 years back. And at that time when I started, everybody said that don't start it. You will start putting less stents than more stents. So do a IVUS if you want to put a stent, and do FFR if you don't want to put a stent. That's how it started. But now I think it has come off. It has really, this technology has progressed so much that we have to learn more about this and how to use this in our clinical practice. Now, look at this, how it has grown. So the FFR, which still remains the gold standard, and then followed by the whole family here of physiology, starting from resting PDPA to CT-FFR, QFR. So I'll take you through all these alternatives which FFR has, kind of grown into and developed. And these are I must say, the children of FFR which have come into the picture. So let's start with the FFR. Where do we stand? The FFR is the gold standard in invasive physiological diagnosis, and it has been really based on three big trials, the DEFA, the FAME, and the FAME2. And it was very, very well established that FFR-based intervention helps, reduces the number of stents, reduces mortality. But the problem is, it's not simple. The problem is that only 20% of interventions today worldwide are being done by FFR guidance, and more than 71% are done by angio guidance. So what is the reason? Why? The reason is that FFR takes extra time while you are doing the intervention, and everybody's in a hurry. The second is it adds to additional cost. And especially in the context of Indian patients, as you know that the cost of FFR is slightly higher than cost of a stent. So people think that why use it? Then the third thing is that the risk of giving, the vasodilator agents, the need of giving vasodilatation, it is expensive. If you give intravenous infusion, it costs a reasonable amount of money, because you have to make, several ampules have to be broken to make the infusion for, adenosine. And then of course the side effects of these medications. So all in all, it led to this poor uptake of FFR despite being substantiated by huge big trials which led to benefits for the patients. So this started us thinking, and then we started moving towards cheaper, quicker, and tests with less side effects. And that is the journey of this NHPR, which is non-hyperemic pressure ratios, and also then now considering whether we should do a phase specific or a whole cycle index in these NHPR investigations. And all these are wire guided, but now we also have without wires, which means we can do FFR in a CT or a normal angiogram, which I'm going to discuss with you, the CT FFR and the QFR, which is quantitative fractional reserve in patients who are undergoing just simple angiograms. So that is the situation right now, and that is the evolution of coronary physiology. We started with just a catheter inside, putting a small catheter, measuring the PDPA, and now moving on to this system, which was the pressure wire, which we started about 10, 12 years back. Then Volcano, there's another company which made it, and many, many companies started making this. Moving on to IFR, which is now we have two big studies, which I'll discuss. And then of course the QFR, which is the angiography based FFR system, and the CT FFR. So it has been evolving quite rapidly. So we have to make our choices right, so that we give the best to our patients and have the best outcomes and see how they correlate with each other. So this is the options which we have, the hyperemic options and the non-hyperemic options. In the hyperemic options, we have FFR and the contrast FFR. And in the non-hyperemic option, we have two divisions, the whole cycle reserve and the full cycle reserve. So in the whole cycle, or in the phase reserve, which we have the RFR, the DFR, IFR, DPR, and DFR. So it is a little confusing, but I'll clarify all these various modalities as to where do they stand today in terms of their usage and in terms of their evidence, in terms of their relationship with FFR. How do they kind of match with each other? So FFR, as you already know, is the concept is that you treat ischemia, not the stenosis, and we have to create hyperemia by injecting adenosine. And these are the three trials which I already mentioned to you, and they clearly showed that FFR guided PCI was found to be better, and FFR guided decision making between medical therapy and intervention was better when FFR was chosen. So that is the premise on which every physiology thing got established, and this is the way things happen, that the clinical data shows that there is a change in patient care decisions if we do this. But the usage, as I already mentioned, was little low as what was expected that it probably will be, because there is an additional thing you are doing. So then move on. So then what happened was that to make things simpler, we started looking at contrast FFR. Means that you do not inject adenosine, you only inject contrast, which we do during an angiogram, and see what happens. So there were three studies which were done: the Renaski, the Memento FFR, and the contrast study. And it showed that if you just inject contrast and use the same pressure wire, then what you get is that there is a value which you get is 0.83 or 0.88, and this was the cutoff which was found, that if you have a value of less than 0.83, which means you can stent without using adenosine, and if you have a value of more than 0.88, that means you can clearly send the patient back. You don't need to do anything further. But what happens to the values between 0.83 and 0.88 in this contrast, I will call it a simplified FFR, where you just put a contrast and check it. So those who are equivocal between 0.84 to 0.88, then we said, okay, let's have the hybrid, which means then you inject adenosine and then clarify. So if on adenosine, the FFR goes below 0.8, then you perform PCI. If it remains above 0.8, then you defer PCI. So this is a hybrid approach which is done with the same FFR wire, and this is known as contrast FFR along with hyperemia if required. Now, this is all about FFR, how do we use it? But then now let's look at non-hyperemic physiological indices. And here is the whole cycle, cardiac cycle index, which is the PDPA ratio. And this can be done again simply with the same wire. And here what happens is that the cutoff is 0.92, which has been found that if you have any value which is above 0.92, you can defer, and the values below 0.92, you can treat. But the problem with this is that it has a, the ischemia threshold is variable sometimes, and it is less reproducible and is susceptible to drifts, so which is probably not so good. Then the other index which are available, which is the RFR, which is available. I think Abbott does it in India, and it has it does the lowest instant PDPA in this, and this is the comparison which has been found. The diagnostic accuracy is about 79%, and the positive predictive value is 88.7%, and the cutoff in this is 0.89. So if anybody has a RFR of less than 0.89, this patient needs to be treated, and above 0.89 they can be deferred. So that is the RFR, and there were two studies there. This is the Illumine 1 and the Predict study, where this was compared in 299 patients. And this is the RFR. How it works is that it takes 5 cycles average, and the value is 0.89 for the cutoff. And this is the validate RFR study, which was done with 651 measurements, again showing a good correlation with IFR, which is another resting index. So RFR is a resting index, IFR is a resting index, and then they were correlated with each other. So what is IFR? IFR is again a resting index using the pressure wire, and this in India it is supplied through Boston Scientific, and this is an instant free ratio which measures in the diastolic wave-free period. And there are 2 big studies which have been recently released, which is the Define Flare and the Sweetheart study, where this technology has been compared with FFR. And this is the wave-free period where we measure this, and this is exactly how it looks. And then these are the results of these 2 studies, the Sweetheart and the Define Flare. What it was done to show is that whether it is the same as FFR or not, and it showed that IFR is non-inferior to FFR. So which means that IFR, which is a resting index, which removes this hassle of giving adenosine in these patients, you can typically measure the and make the decision of deferring or stenting a particular lesion. So these are the 2 pivotal studies which have been recently 2019 and were presented and published. Sorry, 2020. Now we move on to the DPR, which is a diastolic pressure ratio, and it is equivalent to IFR developed by another company, but certainly something similar to IFR.
Acha.
Then we have DFR, which is the diastolic hyperemic free ratio. Again, the cutoff for this is 0.89. So same as IFR. So all these are similar because they are measuring resting index at the baseline. Now there is a meta-analysis which is available comparing. This is a registry, IRIS registry, which compares 5 resting gradients, 5 resting pressure indices, and these are the various ones: FFR, the resting PDPA, the IFR, DPR, the RFR, and DFR. So just to see how they compare with each other, and interestingly, they compared quite well. As you can see here, that they are all in the same range of 0.74, 0.73. Very much matching with each other, and the cutoff values were also quite predictable in all these index, which were compared with FFR. As you can see here, prediction of FFR 0.8 was correlating with the FFR of the resting index of 0.89 with IFR, RFR, and others. So which means that the resting indices are also a reasonable way to assess the physiology of these vessels which are having intermediate lesions. Again, looking at the accuracy, sensitivity, specificity showed that it is quite predictable to do any of these resting indices compared to FFR. And these have similar outcomes as you are seeing here. So deferring a lesion or stenting the lesion in these studies were quite predictable. Now, these were the resting indices which are done by the wire. Now, some people said, why just even put a wire? Why not just have something on angiogram, basis of angiogram? So this is very interesting. This is an angio-based, no intervention, nothing has to be done, just a simple angiogram, and you can know the FFR. So there are several studies which have been done with this. We have to do 2 projections 25 degree apart, and this is basically done in these studies, the favor pilot study, the favor Japan, Europe, and China, and it takes about 5 to 7 minutes to do the calculations through that algorithm. And the problem is that you cannot assess in ostial lesions, severe tortuosity, overlapping lesions, and bifurcation lesions. So in this, it has a limitation. So angio-based thing, this is a standard angiogram. The data is transmitted to this system, and then it starts doing a 3D reconstruction. And based on these fluid dynamics start calculating and give a value, which is the QFR. So this is the QFR, and this is one of the systems which is going to be available in India. It is now actually acquired, but going to be available in many centers. There is no wire to be used, no adenosine to be given, and it is feasible in any lab. So you just need to acquire the system, and then it starts calculating the whole thing. So that is about the QFR, and this is how it is done, that you do take 2 shots 25 degrees apart, and these are fed into the that system, and then it starts making points, and then the QFR technician can make this assessment. So these are the views which are prescribed for the different arteries: left main, LAD, LCX, and RCA, and typically 3 cycles are required in each cine at 25 degree angulations, and that's how we start getting the out results. You can see, and this is the studies which are now available with these, and they found that it is quite comparable again with FFR, QFR versus FFR at fixed flow, contrast flow, and adenosine flow. Very, very predictable, and the overall accuracy was up to 87%, which is quite interesting. So based on this, there are another 2 studies which are ongoing at this time. The favor 3 from Europe and Japan, 1,000 patients in each arm, and the favor China, which is 2,000 patients in each arm, showing comparing the QFR and the angio-guided intervention. So these are the 2 important studies which will tell us whether really we are going to just use the QFR, and maybe FFR may not be required. So this is the study which was just published recently, and this is the clinical implication of QFR on PCI, and it showed that achieving a post-PCI QFR of in these patients should be a target when treating de novo 3 vessel disease. So basically, it is a very, very interesting technology, which is really, if it really works well and it is widely available at a good cost, it will be a good substitute to routine FFRs or IFRs. Now going to the last part of my presentation is the CT-FFR, which is done on the basis of 3D coronary angiographic evaluation on CT, and it is also has a threshold of more than 0.8. It is done through a heart flow calculator. The only problem is that the data is still not so strong or robust to say that we can start doing it in every patient as a starting point, but certainly it has shown very positive outcomes in these patients, and it is non-invasive, so maybe it can become like a gatekeeper for those people who are high risk, who are having chest pain with not too much of positive biochemistry, etc. And these patients it can be done. So this is the quality of life analysis, and economic outcomes showed that in symptomatic patients with intermediate probability of CAD, it is lower cost than invasive angio and leads to greater improvement in quality of life than usual non-invasive testing. So it is probably going in that direction. So look at these three cases which I just picked up from Dr. Hiroki's presentation, which he did comparing these three technologies. Look at this: the CCTA, the FFR-CT, the CAG, and the QFR. So they look at this, it shows that it is almost equal. They are showing good correlation between the angiogram and the and the CT-FFR and the QFR. And again, similarly, in this blockage of about 50-70% on CT, look at this FFR, QFR, and CT-FFR, very, very comparable. So it is having a great promise, all these technologies. However, in some patients, it may not be so much. And in here, you see that in this, the FFR CT was low, but the FFR on the angiogram was 0.92 and the QFR was 0.86. So these are correlating more, the QFR and the FFR than the CT-FFR. So we have some gaps still in these technologies, but certainly we are going in a very positive direction. So with all this enthusiasm and the use of this physiology, OCT also added this computational fluid dynamics. So on OCT images, we can calculate the accuracy of or calculating this FFR. This is known as OFR. So OFR means you are making a FFR calculation based on the OCT images. And this is very appealing, but this data is preliminary and shows up almost 90% accuracy for FFR with this OCT. So maybe one technique can do both the OCT FFR like OFR or the IVUS FFR, which is the imaging FFR with IVUS. So to conclude, FFR is the gold standard still. It's a class 1A recommendation and has a cutoff value of 0.8. Resting indices like RFR, IFR, DFR, it is convenience. The convenience is immense to measure and are as almost 80% or more accurate as FFR. The CT FFR might play a role of a gatekeeper to the pathway of coronary angiography, and QFR obtained during angio can help making decisions by identifying functionally significant lesions. It will definitely reduce the procedure time, the risk and cost, and of using a pressure wire and to induce hyperemia. So these are, this is the situation. So this, I will say, has changed. The pyramid of diagnostic accuracy, where you started from FFR, but now we can even reverse it and say that do FFR CT in an intermediate situation, then can proceed for an angiogram. And if there is an issue, QFR can be done at the same time. And if there is an intermediate lesion on QFR, do a wire-based FFR or the resting indices. And then finally, if we are still in confusion, then do FFR. So that's how we can use all this technology in our day-to-day cases to reduce mortality, reduce restenosis and stent thrombosis. So that's our aim, actually, when we are treating these patients. So I must say, my friends, that angiography alone may not be sufficient to guide revascularization or get better outcomes. And so this is how it compares. The technologies, the non-invasive and the invasive. In the invasive, we have the pressure wire-based, phase-specific or whole cardiac cycle, or coronary angiographic based, which is the QFR or VFFR, or the coronary intravascular imaging based, which is the IFR, or the OCT FFR and the IVUS FFR, outcomes, and of course, finally the CT FFR. So all this is now available. You can see that the spectrum is so wide, but there are some differences which you can really take into consideration while you're choosing your device in a particular patient. So finally, FFR still is the gold standard. The resting indices and the non-invasive indices are really front runners, and the race is still on. Whichever is the best, we don't know, but I'm sure in the next few years, the gray will be very, very clear, and we'll know where we are in terms of using these various kind of indices in our patients to make the right decisions. Thank you very much.
Thank you, Praveen, for your excellent exposition of the subject. It is one of the best lectures I have ever heard on the physiology. And I think you have discussed about all the nitty-gritties of the procedures. Now, in your lab, what is your procedure of choice? I think FFR or RFR, because you can do with the Abbott machine both together, FFR and RFR. And if that, do you go for routine hyperemia?
Yeah, that's a very good question, Dr. Kahali. And now the good thing is that we have the FFR and the RFR in the same machine on the same wire. So what we do is, with the same wire, what we do is we first check the RFR. If the RFR is clearly delineating the case, then we go ahead with the RFR. But in those situations, which is a borderline zone, there we additionally do the FFR, which means then we only inject. Or the second thing we do is, when there is a confusion, first we do the RFR and then we do the contrast FFR, which means you just inject the contrast and check it. If still it is cleared, no further testing. If it is not cleared, then we do the hyperemia with adenosine. So that is our pathway typically in these patients.
And you mentioned about QFR, that the cost will be less. I don't think the cost will be less, no, maybe little less, but not much less. I think they will be charging something for the extra procedure. But what we can, benefit, that we can reduce the time of the procedure, and we can reduce the intervention portion, because you have to give a FFR wire, because especially we see it in side branch evaluation, and it is sometimes difficult to go through the start of a stent to the side branch, and in all those situations, I think it will be little better. Have you got any special comment regarding side branch, this evaluation with these new procedures, and what do you feel to be the best, and what is very convenient and cost cutting? And also non-time consuming, means you can do it in a very small time, very little time.
So with the RFR, I think the job has become very, very easy now, because what we do is these days that I typically, rather than putting a normal wire in the side branch, for example, if I'm doing a left main and there is a borderline lesion in the circumflex and we have to treat the left main to LED, then what I do is I put the pressure wire in the circumflex and then connect it to the RFR, which is like continuous monitoring of the side branch. Same way to any significant side branch, I put the pressure wire, and then we keep monitoring. If everything goes well, then we don't need to do anything for that particular vessel. So that is one of the ways we, I typically do, and many of us do it, that, we continuous monitoring of RFR during the procedure for the side branch. However, in some patients, if I have not used it, I can still take the wire in the side branch, be it a big diagonal or a big M, and put the wire, check the FFR, and now, especially with the RFR, it is so easy. We check the RFR quickly, and then we take the decision to defer or to put the second stent in the side branch.
Yeah, and now you have a Bluetooth technology, so you don't have to attach all those things also. You can do it very easily, because those were cumbersome, attaching, and that takes little time. But do you gel the wire in the process? do you gel the wire in the process? Because if you keep it
Yes.
continuously in the side branch, you have to gel it. So do you gel it also? And
Yes,
that doesn't
absolutely.
cause any harm to the procedure.
Nothing. So the wire, works very well with the jail also, because initially we had this apprehension in mind that maybe by jailing or doing any kind of a compression on the wire, it might lead to some difference in
Fracture
outcomes.
or, yeah,
But we saw
yeah.
that there is no problem. It works as good as the normal wire.
Okay, fine. And in your opinion, because you are one of the leading, interventionist, and also you are the past, chairman of NIC, from your great experience, what do you think that, what is the best approach, this FFR plus RFR? Or you think if QFR is there, it can replace these procedures? Because we can shorten the time, we can reduce the time.
So as I said, I'm looking for the Q. I was speaking to somebody today that I must start the QFR tomorrow because it is there. We have the license in India, and
Yeah, yeah,
SMT has the license. So we have to start
yeah,
this, and it is basically per patient. I think the cost will go like per patient for the calculations every time. So if we have this, I think certainly we'll have it, and then the pathway will become like this: that we do angiogram, QFR is kind of inbuilt, or you want to do it in a particular
yeah,
case, and then go
yeah.
on to make your decisions subsequently based on IFR and of course, or IFR or RFR. They are like similar. So let me clarify this
Yeah.
point that IFR and RFR are interchangeable. IFR is a different company, RFR is a
Interchange.
different company. Yeah.
Yeah, yeah.
And final
And
is FFR.
Dr. Patrick Service, if you remember, you were in that meeting, STEMI meeting. Ramesh was also there. You and Ramesh had great parts in the meeting. And Patrick Service had a live transmission from his center, and he has shown this QFR technology in that meeting about 1 year and 3-4 months back, that it is a very good technology and very accurate one. So that will save some of our time, and I think hopefully some of the cost also. And again, I should congratulate you, and it is open to the discussion. So Ramesh, any comments? How frequently do you do FFR nowadays
Yeah, so
in
now
your
I think,
practice?
yeah, a very good lecture by Dr. Chandra, and it's really, you covered everything in FFR, and as you see that it is
Yeah,
growing. So initially we were at about 20%. I'm talking about maybe 10 years ago. Now, actually, it goes up to almost 60 to 70%. I'm not talking about 100% occlusions or 80% and above occlusions,
yeah.
but anything less than 80%. And actually anything more than 40%, we actually intervene. We do FFR first and then decide whether the patient should go for bypass surgery or PCI. So I would, that's one thing I would recommend is that, stop just believing in your own eyes. I think a 40% lesion in LAD might be actually abnormal. So you might think that, oh, this is just 40% lesion, I'll leave it alone. No, once you start doing FFR, initial fear was that we will reduce the number of PCIs. That actually is not true. In fact, if it is a small RCA, if it is 80%, it could still be negative, so you don't have to intervene on that. And likewise, I think if there's a 40 or 50% lesion in the LAD, that might become abnormal.
Absolutely.
So what is the
I totally
threshold,
agree.
Ramesh, for proximal LAD lesion? Yeah. Ramesh, what is
Yeah.
the threshold of intervening for proximal LAD lesion before the first septal?
Oh, I mean, I
50%
think,
or more?
yeah, more actually.
Yeah.
If there is a proximal LAD moderate lesion, and first of all, we should do FFR or IFR. We do both IFR and DFR in our hospital, and so based on that value, we go ahead and intervene on that. I mean, obviously, you can discuss about diabetes, and if there is diabetic insulin dependent, then we will say that probably PCI versus cabbage. But if non-diabetic or even non-insulin dependent diabetes nowadays, if it's a large vessel, discrete, we are proceeding with the PCI in that.
Even for a single vessel disease like a proximal LAD lesion, you would think about going for cabbage with a Lima 2 LAD.
Yeah,
With rather
absolutely.
cabbage, rather a small MICS, I mean, that mini invasive cardiac surgery.
Right. If smart
Yeah, it
question,
was a
Dr.
wonderful
Kahali.
lecture. Yeah.
right? Dr. Kahali is trying to get me into trouble. There is something called appropriateness use
Not at all.
criteria.
Not at all. You are always that, and, we call it as Bipat Tarini, in Bengali. And you always take us out of the woods, because Antonio is busy in some emergency, and he was giving us the feedbacks that every 10-15 minutes he will be coming, but unfortunately he couldn't make it finally. So Ramesh being our Bipat Taran, so I would request Ramesh, if all the questions are over, Dr. D.P. Sinha had a question that whether we would go for FFR in all the patients. Yes, Dr. Shetty, you can have your question.
Yeah, Dr. Praveen, of course, superb talk. There's no doubt about it. First, of course, the indication, as Ramesh mentioned, that we are selecting for intermediate lesion only, isn't it? Like, 40 to what, 80% like that. That is one. Now, again, as Ramesh rightly said, LAD, 40-50% as against the other artery, may have a different significance. And the third thing, like you are using FFR for now 10 years, Now you think, your using of FFR is gone down after this all RFR and your IFR data, etc. Like, significantly gone down. And then that QFR is for all the, any equipment, any cath lab machine can be, it can go with any particular machine, or how is it, technical point of view?
Okay. So very nice questions. Thank you, Dr. Shetty. And basically, as you know, the first thing is about the QFR. The QFR is applicable to any digital cath lab, which can give digital output to that, the equipment which calculates just the functional, the flow dynamics, and then gives the results. The only limitation is that you have to make 2 angulations at 25 degrees, and then typically the view should be fixed, and take 3 cycles in each cine. So that's how it is done. The second thing about the use of FFR versus IFR and RFR, has it gone down? So let me tell you, in the last 10 years, we have been really using the physiology usage has gone up. The only thing is that now it is split into 2. The same wire, it is the same wire, it is the same machine, the analyzer. But if we get a very clear-cut answer on the RFR, which we are using RFR, we were using IFR earlier, but it was limited for some time, and then it went away. Now we're going to start again, because they are both in the same machine. So if you are using the Volcano system, it is IFR plus FFR. If you are using the Abbott system, it is RFR plus FFR. So we do a RFR, and if we need, we do the FFR also at the same time. So it is like divided 70-30. 70% times we still do a FFR, but 30% times we get away without doing FFR.
And that intermediate lesion, and like Ramesh mentioned,
that's a good question.
Like, what I'm saying, like, when we see angiographically, say, significant lesion, like, anything like more than, say, 80-90%. So we don't require to do, isn't it? Is it like every time, like a functional checkup? Because sometimes I get a, some message in some discussion, like, like a overuse of thing, functional testing.
No. So basically, it has to be done in an ambiguous situation. Whether there is ambiguity about the lesion severity, there is ambiguity about the symptoms of that particular patient, or the ambiguity about how much myocardium it is actually supplying. Many times, even if it is a 80% lesion or 85% lesion in an OM, you do FFR, you will find it negative. And then you do the same FFR in a borderline lesion in the LAD, and you find it positive. So that is where the huge advantage is there, that rather than treating that small OM, which is looking 90%, you are leaving behind the LAD, which was actually the culprit. So this is where we have to mix and match and use our judgment to really optimize the use of functionality or physiology in these patients. As
Absolutely.
Dr. Neeman also mentioned.
And what about the post-procedure doing FFR? Are you doing regularly, or is it more of a like a theoretical thing? There are some paper like a post, like you see the residual ischemia, etc. Is it done routinely, like after an intervention, just to demonstrate, since the wire is already in your hand? just to show that, you have done the revascularization good, Is it done as a regular basis in your lab, or how is it?
No, we don't use it routinely, the post, but certainly in those situations where there are multiple lesions,
Yeah.
where there is a plaque up there and a plaque down there, then we typically do FFR in these patients.
Yeah.
But otherwise, if there is no tandem lesion, if it's a clear-cut situation, then we just do a pre and then follow it up with a OCT maybe sometimes. Because mostly either we do a OCT or a IVUS in these patients to substantiate the final outcomes of the stent.
Okay, thank you very much. Thank you, Praveen, for your excellent, superb speech, beautiful exposition of the subject. Wonderful. Thank you very, very much, and congratulations. You have been, as usual, in your best. Now, my great friend, Ramesh, who has taken out from many troubles, us many times in the past also, is going to talk about PCI for in-stent restenosis, whether drug-eluting balloon or drug-eluting stent. Ramesh, please.
Thank you.
He is excellent. He can give lecture anytime on any subject. Great.
Good.
Thank you very much, Dr. Kahali. Great pleasure to join all of you. And in a short time, I just compiled few slides, and bear with me if they're not up to your standards. So, background of why drug-eluting balloons are coming up now is because it is known that from late basket trial in 2006 that stent thrombosis rates are much higher with the first generation drug-eluting stent. So if I don't think, if it was purely, we started off the first generation with Zions and Onyx, I'm not so sure that drug-eluting balloons would have come into place. But yes, there is a late stent thrombosis or very, very late stent thrombosis going up to even up to 3% in sirolimus eluting stents, as well as with in some of the everolimus eluting stents, it is still about 2.3%. So that is the problem, and that we know that, and how long should we do DAPT in people with the high risk is another problem, why there is even a need for drug-eluting balloons. And so when you think about DCB only strategy, there's no potential short and long-term disadvantages, such as with the stent implantation, and the reduction probability of restenosis observed in the POBA era. And then with the paclitaxel eluting balloon versus drug-eluting stents in primary PCI, I'll probably show in one study about that. And efficacy, you can look at a primary endpoint. What is the primary endpoint, whether it is fractional flow reserve, and secondary endpoints such as late lumen loss and major adverse cardiac events as well. And safety, stent thrombosis, and major bleeding, such as Bach bleeding. So here is my patient, 40-year-old non-smoker, unstable angina, and PCI proximal LAD done in 2006, original Cypher stent. And in April 2010, he presented with diabetes, non-ST elevation MI, ostial LAD stenosis, and so PCI of the LAD was performed. Then he had ostial circumflex stenosis with the dissection at the time. So he had a stent from the left main to circumflex as a bailout, and all were Taxus stents with the final kissing balloon. And so ECG showed, now when he presented, ECG showed T inversions in V1 to V4. And echo in the beginning was 60% EF, no regional wall motion abnormality. Here's the index procedure, as I don't have many of those pictures, so Cypher to the proximal LAD. And so then he came back in 2010 with the restenosis, which I don't show, the LAD restenosis was tackled with the PCI with the Taxus, and then that resulted in dissection, and left main to circumflex stenting was done. And these were done actually at outside hospitals, and you can see that post dilatation was also performed, and final kissing balloon, which was satisfactory result in April 2010. 4 months later, he comes back with unstable angina, and now you can see there is both bilateral, ostial LAD and circumflex restenosis. And what next? Same drug-eluting stents. I think I showed this slide at Sky in one of the meetings in Mumbai. So then drug-eluting balloon was done to LAD and circumflex, and here is a patient who had a prior stents, cipher now to the LAD, and then taxis, and then again restenosis. So obviously failure of the first generation drug-eluting stents, and so DEB was done. And 6 months later, check angiogram showed actually still restenosis of the ostial LAD and some moderate circumflex lesion as well. So what next? I think a cabbage again, or a different drug-eluting stents, or PCI with the same drug-eluting stents, or again drug-eluting balloon. So here there's a DK crush was performed in 2011 using Promus drug-eluting stents. Now, so that we have come into the second generation, which was successful, and you can see excellent angiographic result. And but he came back later. I'll show that. But the mechanisms of instant restenosis you have to evaluate, and biological factors, whether drug resistance and hypersensitivity to the metal of a stent platform, or mechanical factors such as stent deformation and fractures, which I saw with the cipher, and not much with the second or third generation drug-eluting stents. And technical factors, this is always common: incomplete stent expansion, and stent gaps or misses, and barotrauma to the unstented segments as well. So he comes back again in February 2012, and now there is some restenosis again in the ostial LAD, and you can see that there's not completely well deployed as well in the IVUS pictures. Whether IVUS should be used in all lesions, now at least we have some data saying that by randomized clinical trial. But before that, in all two stent techniques, using IVUS definitely reduce the risk of stent thrombosis, and cardiac death is also slightly on the cardiac death is 0.9% versus 3.3% in people who did not get the IVUS. That said, in a randomized clinical trial such as Ultimate, which showed only in the non-bifurcation lesions that IVUS is superior to non-IVUS studies. Now we are looking at the DK Crush 8, which will be addressing the use of IVUS in bifurcation lesions. So, and we have to wait probably for a year for this study to come out. How about radiation? So we still are trying to get a brachytherapy back into our cath lab. We used to have brachytherapy, and then we shied away because of very, very late stent thrombosis. Even after 3 years, we were seeing some stent thrombosis. But I think radiation still definitely has a role in affecting the S2G1 phase. And we can probably look at some of the studies that have shown the superiority of, or actually non-inferiority of brachytherapy. So outcomes, as we said, that very late stent thrombosis is on the rise, and now choosing patients appropriately after 2 recurrent stent failures with restenosis, probably there is still a chance. But that said, 20% TLR and 30% TVR rates in people with brachytherapy, and 13% death at the end of 3 years, and patients with these patients who had very late stent thrombosis due to brachytherapy. So our patient presented back in September 2012, again with late stent thrombosis, and as you can see in the ostial LAD, and here he was treated with again POBA, and he remained asymptomatic till May 2015. And so that I think somehow you have to consider how to best treat of this recurrent stenosis. As I said, the role of imaging is very important, probably role of FFR before we even think about stenting is also very important, as covered by Dr. Praveen Chandra. And we have to make sure that the technical adequacy is performed, especially with the trials that we're talking about in diabetes. We need to make sure that all the diabetic patients are sized properly based on OCT or IVUS, And undersizing is a very big problem I see, which we need to overcome. In a proximal LAD, there is never a need for a 2.5 millimeter stent. So if you're going to put a 2.5 millimeter stent in a proximal LAD, I think we have to seriously think about that patient and do an IVUS. So in people who have unprotected left main drug-eluting stent restenosis, what did they come back for? If you look at them in the 71 from Korea, 71 restenotic cases, 57 of them were focal and 14% of them had diffuse ISR. And then these patients, majority of them presented within 1 year. And they were treated in 3 methods: CABG, PCI, and medical therapy. As you can see here, the CABG at the end of 5 years, 90% MACE free survival versus PCI is 86.4, and medical therapy is also close to that and 85.6. So I think if there is focal stenosis, you can go ahead with medical therapy. If there is diffuse stenosis, I'm sure that those patients will benefit from either PCI or bypass surgery. Let's talk about the drug-coated balloon quickly. As I mentioned, there are 5 randomized controlled trials of bare metal stenosis, ISR, that were treated with drug-coated balloons, and here versus POBA or DES. So in PACO-CAT, the ISR, DCB is better than PTCA at 6 months and 2 years. And with the PEPCAT2 ISR study, DCB at least as efficacious and safe as first generation drug-eluting stents at 1 year. And the results were maintained up to 3 years as well. In the RIBS-5, drug-coated balloons versus DES and second generation DES. DES is associated with superior angiographic and similar clinical results through 1 year, and reduced the TLR rates observed with the drug-eluting stents versus drug-coated balloons up to 3 years. So I think that is where the dilemma has been, because if it is a cipher versus a drug-coated balloon is better. But if it is science or onyx and all the others, Biotronic, or Cyro versus drug-coated stents, I think RIBS-5 showed that the drug-eluting stent is better than drug-coated balloon in bare metal restenosis. How about in drug-eluting stent in stent restenosis? Because nobody is using bare metals anymore, as much as I know. And so 6 randomized controlled trials, and you can see that actually here the most important one is RIBS-4. Again, DES is better than drug-coated balloon with superior clinical and angiographic results. Then ISR Desire 3. Here was the 3 ways of looking at it. DCB is non-inferior to drug-eluting stents and superior to PTCA at 6 to 8 months. And the same efficacy was maintained up to 3 years, and it was safe as well. So I think ISR Desire 3 does support the drug-coated balloons as non-inferior to first generation drug-eluting stents again. But whereas RIBS-4, when you are looking at second generation, which is our current practice, I actually think that drug-eluting stent still is the way to go. As you can see here in everolimus eluting stent in the right, the 3-year clinical follow-up, freedom from death, MI TLR is 85% versus 75% with the drug-eluting balloon. Despite all that, at least in ESC guidelines, they do recommend the drug-eluting balloons are recommended for the treatment of instant restenosis by bare metal or drug-eluting stents as class 1A recommendation. In the United States, we do not have such recommendations yet. We still have to wait. At the end of this year, we'll get some new PCI guidelines, and hopefully there will be some support for drug-coated balloons. So drug-coated balloons was a second generation. This is Antonio Colombo's study. He looked at, and I'm sure he would have presented that, this data in the management of metal layered instant restenosis. If it is first PCI with the bare metal or drug-eluting stent, second PCI was performed with drug-eluting stent for ISR. And then if the patient comes back with the second generation ISR, then drug-eluting stent implantation or DCB for ISR was done in 179 lesions between 2008 and 2013. So he compared 82 lesions in 68 patients with the second generation drug-eluting stents and with the same number with the drug-coated balloons. What he has shown is actually that the drug-coated balloons has a cumulative instance of major adverse cardiac event rates or higher about 43.5% with drug-coated balloons versus 28.8% with the drug-eluting stents of second generation. So obviously, this is a primary endpoint of which at 2 years is in favor of drug-eluting stents and versus drug-coated balloons. But 1 year did not make any difference. So long-term drug-eluting stents of second generation is still much better with the lower TLR and as you can see, and higher MACE rates with the drug-coated balloons. So let's look at what happens in other in acute MI. Is there a role for paclitaxel-coated drug-eluting balloon versus a DES? And here they actually showed that they did an FFR at 9 months follow-up. There is no difference between drug-coated balloons versus drug-eluting stents. So that is actually their primary endpoint, which was really good, and it is similar efficacious. And as I said, even in other trials, we have seen that same thing, that 1 year, the results are similar, and after some time, late catch-up is there for drug-coated balloons. Here, as you can see, drug-coated balloons in the blue have a late lumen loss, which is slightly more than drug-eluting stents, and the late lumen loss in this study in acute MI. With the drug-eluting stents, it's a 0 versus drug-coated balloons is 0.05 late lumen loss, which is not really that bad. And major adverse cardiac events at 9 months is no difference between the two. So DCB strategy is possible in STEMI, and I think that some people are really in Germany, in DCB is being used a lot in bifurcation completely, both for all bifurcations without any drug-eluting stents. How about in small vessels? In small vessels, actually, there is a complete thrombotic occlusion that happened with the DES. And mind you, this is the Zions is a 5 and Taxus is 3. So it is not just a first generation drug-eluting stents. And versus compared to that, drug-eluting balloons, there is no stent thrombosis. So I think in people with small vessels, there is definitely a role for drug-eluting balloons in terms of safety. I'm not talking about efficacy here, but at least we can avoid stent thrombosis in these people. So if you look at the majority of the other patients in the DARE clinical study presented by Enriquez from, in 2017, comparing drug-eluting stents versus drug-eluting balloons, it was a non-inferiority, and the non-inferiority endpoint was met. So drug-eluting balloons in all comers in DARE clinical study had been shown to be similar up to 6 months. So we know that, and that up to 1 year, as I said, it is similar mechanism, a similar efficacy and safety. But the proposed treatment algorithm for patients for in-stent restenosis, in my opinion, if they are coming with bare metal in-stent restenosis, drug-coated balloons versus drug-eluting stents, my choice is always on the right, drug-eluting stents. But if they are coming with a drug-eluting stent in-stent restenosis, you choose either drug-eluting stent or a DCB. If you have the availability of DCB, go for that first. And if they come back in a year, you go for drug-eluting stents. If it is recurrent drug-eluting stents, I think vascular brachytherapy is still a choice if it's not a candidate for bypass, or go for bypass surgery is my opinion. So incidence of ISR, drug-eluting stent, ranges from 3 to 20%. And imaging is important to understand the mechanism of stent failure. And finally, drug-eluting stents and drug-coated balloons are associated with nearly 10 to 20% recurrence at 1 year and with a late catch-up. So drug-coated balloons or drug-eluting stents are effective for bare metal stents, ISR, and the drug-eluting stent is preferred strategy for the drug-eluting stent in-stent restenosis. And the brachytherapy finally for recurrent drug-eluting stents failure. So how do I deal with the recurrent osteal or recurrent restenosis? IVUS first, understand the etiology. Atherectomy if there is heavy calcium within the stent or behind the stent. If it is behind the stent, IVL, which is now available, lithotripsy. And the laser may not work in people with heavy calcium. Drug-eluting balloons better than POBA. And especially if you're using in calcified lesions, make sure you do a scoring balloon or a cutting balloon. Avoid multiple layers of drug-eluting stents to start off with. And brachytherapy is an option. And in my opinion, CABG or medical therapy is still a great option. Thank you for your attention.
Very nice.
Thank you, Praveen. Any
I think
questions?
this was a complete, in-depth, I must say, guidance for treating in-stent restenosis, and I'm really impressed. So, Ramesh, you very correctly said that using a laser, because now we have used laser in the past. Now again, it is coming back in India. So it's going to be available, and we are going to use that. But definitely laser will be one very important tool for in-stent restenosis, but not for calcific in-stent restenosis. That's right?
Yes, that's correct.
Because it doesn't work so well in calcified lesions,
Yes.
mainly in fibrosis and neointimal proliferation. So that's, I think, a very good point you have made. And we have a huge experience now of using drug-eluting balloons of various types. Of course, we have used the paclitaxel eluting balloons. Now we also have the sirolimus eluting balloons, and certainly we have seen almost similar outcomes with these both kind of these devices. And in fact, we did a study many years back where we did two comparisons. One was in patients DEB only compared to those patients where we put a stent, followed it with the DEB at the same lesion. So that was a bare metal stent and a DEB. So it is very interesting to use DEB in these situations of in-stent restenosis, definitely. And I do use it very, very often. I have even done kissing inflations in a left main circumflex ostial and LAD ostial stenosis. Thanks.
Thank you very much, Praveen. I think it is very important, and you have the benefit of having all the drug-eluting balloons in India. And I think it's a good from NIC standard to look at actually even at the registry, both the drug-eluting balloons, what has been the usage and versus actually drug-eluting stents in similar population. Dr. M.K. Das asked me a question in my patient whether I checked lipoprotein little a, ApoB, and hyperhomocystinemia or P2 white-12. We checked for P2 white-12 inhibitor resistance, and otherwise the cholesterol was really aggressively brought down. His LDL was actually 65, and HDL was still on the slightly on the lower side, and it was on the there was no hyperhomocystinemia in that patient. And in the era of prior to reduce it, we were only just giving a omega-3 fatty acids already, which were available at that time.
Thank you, Ramesh, for your beautiful lecture. I was really wondering that it seemed that you have taken 15 days to prepare this lecture. I haven't given you even 10 minutes time. Sorry for the little delay in connecting because the internet went out for a few seconds, and therefore it was a inordinate delay, little delay. Anyhow, it was an excellent, superb, lecture. And you went across the Atlantic to show all the European data, because I think in your country, I mean in US, you cannot use the drug-eluting balloons. So it's a great presentation, and I liked it very much. And it's amazing how within 10 minutes you can organize such a beautiful, beautiful lecture. It was a wonderful lecture, really, Ramesh. And I have seen it in the past, and this time also you have proved you are a great genius. It's a great lecture. And within 10 minutes, it's very difficult to organize any lecture. It's a great thing. Now, regarding, there are some other smaller trials, as you have rightly mentioned, that one is METO trial, that is Milan and New Tokyo experience. I think Antonio Colombo was the PI over there also. And, it showed that there was 50-50 chances, and they used 50% patients DES and 50% DCB, and it was shown that the results were almost similar and the outcomes were similar with both the things. So in smaller lesions, ISR, I think it's very good, and you have rightly shown that for debulking in case of ISR, because it's a very difficult entity, I think sometimes we need rotablation, though no study showed the superiority of rotablation in such situation. Have you the experience of using IVL? Praveen has used in quite a few cases. I don't know, Praveen, whether you have used it in ISR lesions, that he has done in a few other cases. So I would ask Praveen and you also that have you any experience with IVL in the US, or it is allowed over there by FDA?
Yeah. So, Dr. Kahali, again, this has been a very wonderful evening with everybody here and discussing and learning so many things. And Ramesh is really a kind of star, I must say, that he did this
Yeah,
presentation.
really, yeah.
Excellent.
My pleasure.
So the question about, you asked about IVL and in-stent restenosis. Yes, I have done now a few cases now in in-stent restenosis, especially those who were resistant restenosis, those who had 2 episodes of restenosis, and we found that the stent is not well expanded. So in those cases we did, and we found very good results. And also in some patients we did where the balloon was really not holding on. It was like slipping out all the time. And these were big lesions, very heavy chunk of proliferation there. So in these patients, especially, and one was proximal LED. I was doing a live case also in that IVL, and really it worked out quite well. And these patients do respond very well. There is no slow flow or any other complication as we noticed during the usage of IVL in in-stent restenosis.
Oh, excellent.
Ramesh,
So,
can I ask one, Diman?
Yeah, sure.
Ramesh, yeah, I agree with, it's an excellent talk. There's no doubt about it. You covered everything. One question I want to clear from you. Now, small vessel means what size you normally? What is my thinking is like, is it like a vessel size more decision making for even say second time you do put a stent, even in a drug-eluting stent coming with ISR again, do you go by more by the size? And I agree, mechanism wise whatever you explained is quite okay, or essentially we restrict this one is really for a small size vessel, because you showed the second generation stent even for the ISR, the whatever the event wise is comparable,
Right.
isn't it? Yeah.
So actually in the late basket, basket small, they included any vessel that is less than 3 millimeters, which actually I would, in my opinion, less than 2 millimeters is what I consider as small. And above that, I think is okay. 2 millimeters and smaller, I think it is better to treat with drug-eluting stents. And in our opinion, I think in the 2.25 is one study looked at small vessels as being less than 2.25 millimeters.
Okay.
And Dr. Srinivas there? Dr. Srinivas Kumar there?
No, he had to leave.
I think he has left. Yeah. Dr. Neeraj, you are making some comments.
Yeah. Okay. Good evening, everybody. Nice to see you all after a long time.
Yes.
Yeah.
And, first of all, I have a good experience with this drug-eluting balloon also. And most of the thing which is my experience, which I'd like to share with you. First is that which group of people they required it. The first thing I found that because I'm in Jharkhand, I'm in Ranchi, so in this tribal population, they have a very thin blood vessels, and they are the thin blood vessels, and they are tortuous also, and walls are also weaker. In these cases, I think balloons are safer than stent, especially when the lesion is going across the curve. Similar thing I have also seen when I was in Pondicherry, where I have seen the South Indians population, especially Tamilians from the rural belt. They also had a very thin blood vessel and very tortuous blood vessel. And there they are doing it with the stent was almost not possible. So in those cases, I think the first choice is this, and my choice now is Magic Touch, and which is the very good balloon, drug-eluting balloon, and I've used it so many times. And even for the best thing is that why is that drug-eluting balloon fails compared to drug-eluting stent and the in-stent restenosis? The reason being is that the when we put a drug-eluting stent, we find that 100% there is elution of the drug at least 95%, 100%, and new group of groups almost 100%. So that serves as a very good antimitotic agent, and the proliferation of cells and endothelium doesn't occur. But when we are using drug-eluting balloon, which are used before, the drug elution was around 20% as per the study. So there was a re-stenosis again. So that's why this new technology, this nano-lute technology, the drug elution is around 95 to 100%, and there is no other issue. So then the re-stenosis rate, what I have found, is very low in this group of patients.
You always predilate the lesions with some other balloon, isn't it?
Yeah.
Yeah. And then you give this balloon, you know.
Yeah, then we give the drug elution.
Always we should do it, you know, otherwise, yeah. Anyhow, I think we are at the end of the session. I would invite some other comments. I think it's thinning out also because it's dinner time. And I would thank Ramesh especially because you have given 3 hours time to us, and we have again embarrassed you by requesting you to deliver the lecture. And I must mention it again that you have done an absolutely fantastic job. Your lecture was superb. And I would also congratulate Dr. Praveen Chandro for giving such an excellent exposition of the subject. He included each and everything, including CT, FFR, and QFR, all the new technologies which you have been noticing globally. He has incorporated everything, a very nice comparative data. Thank you, Praveen, for being with us all along. And I also request all of you present over here, I think many luminaries and dignitaries, to give your suggestion to continue this educative program. And you know, I would invite all of you to be present, and if you kindly send your suggestion so that we can have a nice group of young interventional cardiologists who will have a great knowledge, and they can you know, practice it in our general population, you know. Like, you know, economy is a burden, and especially after the COVID, so many people have become unemployed, and this is putting further economic pressure on the economy. So under these circumstances, we have to go our own way, because excepting for a few metros, all the people cannot afford everything possible which is there in the science. So we have to have a good combination of both. And I would request you, just like what Ramesh told, that we can have a registry between DCB and DES. Like that, we are thinking of doing some other things also. I'll be in touch with all of you. But I just request you, Shadanand also, and Srinivas has left. So all other, you know, senior persons who are there, to please let me know what is your thinking and how we can proceed. Because this is the first one just to start, and we'll have these, you know, educative meetings one after another. And on 31st of October and 1st of November, we are going to have the CSI and NIC annual virtual meeting, because initially there was some problems regarding, you know, some people thought these are not very popular meetings. Anyhow, we have to go ahead. And again, I thank you all for your you know, kind presence and active participation. It was a greatly successful meeting, and I hope it will grow popular day by day. Today there is another meeting in South India. I was also invited. So, you know, I think it was a great meeting. And I would thank especially Dr. Ramesh Dagubati because of his presence. He was all along there, and he has given an excellent lecture. I am mentioning time and again because it was really a superb lecture. And Praveen, also your lecture was superb, and Dr. Mary Claude Maris and Dr. Roxana Meharan were wonderful, as they are. And Dr. Mehran's you know, discussion was also fascinating. We came to know some of the facts prevailing in that country, which is not here. And anyhow, this was a very good meeting and successful meeting. And I would request Praveen, because you are also a ex-president, chairman of NIC, and then Dr. Ramesh, to tell a few words, and then we can conclude this meeting. And thank you very much, all the participants and delegates.
Thank you, Dr. Kali, for organizing this evening program. I think definitely it was a successful program organized by you, with Dr. Mary Claude Morris and Dr. Roxana Meran, a super and Dr. Ramesh is always helpful. So
Yeah, he's
he is
always
our brother.
brilliant.
He helps us certainly, but we miss Dr. Colombo certainly. In the next, maybe
Yeah,
we can have him.
yeah, we can
And I'm
expect it.
sure you must continue. You must continue this, and we will certainly give our suggestions. And having registries also
I
is a very
need
good
all of
idea.
your help. Yeah, yeah, yeah.
Thank you.
So Ramesh, a few words please from
Yeah.
your end.
Yeah, thank you, Dr. Kali, and the entire CSI chapter. Really, very great pleasure being there with you. I'm also a CSI member, so I always feel I'm a Indian always, and even though
Sure.
I may
You
not
are
have
an
the
Indian.
passport. But I think this is how we establish some research ideas, registry, and we'll be very happy to work with all of you. And great to be part of this symposium. I think the trials that are ongoing are tremendous, like Tuxedo 2, and now this study as well with the Marie-Claude and Roxana. I think this is how we set up ourselves at a higher bar than the rest of the countries to show the data is coming from India now. And all of you as NIC and CSI leaders, I think you're taking a very great step towards the right direction. And great to see all of
Thank you,
friends,
Ramesh.
all the friends.
That's
Great
also,
to
yeah,
see.
really. I enjoyed, yeah. I enjoyed also.
Thank you.
Thank
Excellent.
you, Sadanand, for your active participation. Mrinal, you are there. A final concluding remark? Mrinal, Dr. M.K. Das, our president, he has gone for dinner, I think. Oh, Mrinal is there. Mrinal is there. Mrinal. So, a final concluding remarks from our president, young president. Yeah.
I was really very, very happy that it could ultimately happen because since NIC was aborted because of the corona effect, but we were pushing Dr. Ali that we should do something in a virtual form, and that's really has been successful because of Dr. Kahali, who is the chairman of the CSI NIC, and also with great help from Dr. Debabrata Rai, who have done really excellent job, and all the speakers have done really fantastic job. And I requested also Dr. Dr. Dagubati to present at least some deliberation in absence of Dr. Colombo, and he complied with it.
Great.
Great performance.
Really
Thank you very
great,
much.
yeah.
Thanks everyone for participating in this maiden series 1 CSI NIC meeting.
Thank you, Mrinal. Dr. Debabrata Rai, you are there. Dr. Rai, we have not been seeing you. Dr. Debabrata Rai. Anyhow, I think he is not there. Okay, so last of all, thank you all. And I'm really very, very grateful to all of you. And I announce conclusion of the meeting. Thank you very much. And soon we'll be meeting again. Thank you very much. Thanks.
Thank you.
Thanks.
All.
Thanks.
Bye.